Pleasure to be here and talk about my work. So you've heard a lot about mobile health, just-in-time interventions, and this space already. And so I'm going to talk about an application we're working on, full scope from data collection to actually developing just-in-time interventions for mental health and some of the challenges that arise in this area. And so it goes without saying, clicking on the wrong thing. It goes without saying that we're in a mental health crisis. The lifetime experience of an anxiety disorder is 1 in 4 people, and this is before COVID. And so it's only been exacerbated by COVID, and greater than 50% of people are undiagnosed, and greater than $200 billion a year in treatment costs. And really, we're looking at about 1 mental health professional per 1,000 individuals. And so 1 out of 3 people is getting treatment, and a lucky 13% are getting what's minimally adequate treatment. And oftentimes, 15 to 20 years go by before getting social anxiety treatment. And so our clinics are not enough. Therapists on college campuses are overwhelmed. They're looking at apps and digital health to supplement telemedicine. So the good thing about COVID is telemedicine really blew up, and it became, I think it got a lot better, but there's not enough clinicians to be able to treat people, not to mention people aren't necessarily getting themselves to the clinic because of stigma or other reasons. And so we have to think about alternate care models. So what can we do in the meantime? None of this is a supplement for face-to-face care, clinical care. So we're thinking about stepped care models. How can we use technology to be able to supplement and better treat people with mental health disorders? And so we talked, you heard a lot about wearable data this morning, but traditional medical data is clinical data, therapy, imaging, inpatient monitoring, laboratory results, and genomics. But where does this patient-generated data fit in, and how can we actually use that to better tailor care? And this patient-generated data can provide information about people's affective states, their environment, their activities, their brain health, and how do we integrate that into a stepped care model? And so that's what I'm going to talk about today. So we leave digital footprints on everything we touch, from a wearable device that can provide information about our stress, how active we are, and even our phones. A lot of what the early days in this work, we used just phones to actually understand people's patterns of daily living from the sensors on a smartphone. And so these devices, when embedded within the context of an intervention, can be very powerful. And so we're looking at how do we use these devices to better personalize health interventions. So moving away from a one-size-fits-all model that doesn't consider a person's behaviors, their physiology, their environment, their social interactions. And so how do we leverage sensing, embedded sensing on smart devices to monitor the interactions between behaviors, physiology, environment? And so the first thing I'm going to talk about is some intervention work we're doing at UVA, a collaboration between engineers and psychologists. And so we've been working on this platform for some time. It started as a digital web platform to help individuals with anxiety reduce anxious thinking. And it uses cognitive bias modification, what's called cognitive bias modification interpretation training, which helps people change the way they think about anxiety-inducing situations. And so it works sort of like this. You get a scenario that you might have if you're a person who deals with anxiety that you have to think about. For example, you spot a neighbor on a street. And then you get a scenario that says, as you are walking down a crowded street, you see your neighbor on the other side. You call out, but she doesn't answer you. Standing there in the street, you think this must be because she was, and it forces you to think about how to fill in that blank word. So in this case, if they did this correctly, they'd fill in the D for distracted. And so the idea is to help them interpret these scenarios in a positive way. And so to change over time their anxious thinking patterns. And then they answer the question, did your neighbor purposely ignore you on the street? And ideally, they would say yes. And so we look at their behavior over time, doing a series of these interventions. We've done a test with 737 individuals across a few studies looking at positive scenarios, a mix of 50-50 positive and negative scenarios and no scenarios at all. And we've showed that we can reduce negative interpretations in individuals who complete the program by session 6. So it's meant to be completed over 6 sessions, about a week apart. And they also have a reduction in anxiety symptoms, with only 2% having an increase in symptoms above the baseline. So we found it's generally effective, but there are challenges with that. We have a wide range of users. We've reached about 69 countries to date. And all of these users are very different in their needs. You have students, you have older adults. Like the types of scenarios that an individual needs is going to be very individualized. And so we've done a lot of work to extend this intervention work to think about how we add a human in the loop. So there's a shortage of therapists. We've thought about how you can add human coaches to help keep people engaged in the intervention. We've looked at COVID-linked anxiety, adding to existing care pathways where people are already receiving mental health, tailored to the Hispanic community. We're deploying a version right now, a mobile version, to UVA students, staff, and faculty, where we've done qualitative work to determine what their needs are. But most of what I'm going to talk about today is the last one, thinking about how this can be translated into personalized, just-in-time interventions that adapt to the individual's need in the moment, leveraging embedded sensing. And here's an example of the prototype of the app version designed to give people what are we call them microdoses of the full intervention. The idea is that you don't necessarily have the time to do a full 45 minutes, but can we get you when you're most anxious, when you need it most? Can we provide a version, a smaller dose of the intervention when you're anxious to be able to help you? And so why did we start looking at these different versions? And engagement and attrition is a huge problem in mental health apps. And so, if you look in the App Store, there's a lot of like consumer grade mental health apps. It's like the Wild West, not a lot of scientific evidence to back up a lot of what's out there. But what we saw in our own study is that we had a 97%, we had 3 different studies, 97% attrition rate with most individuals dropping out in session 1. And so that was the biggest point of dropout that we needed to tackle. And then as you go across the sessions, you see a slightly less dropout, but we have a problem. And so we did qualitative work to look at reasons for dropout, some people we're not going to be able to keep, but how do we prevent this dropout and keep people engaged? So we did some work on attrition, and we actually found that the most predictive of dropping out of the intervention at the first session is user behavior within the app, not the actual intervention outcome or the user characteristics, but their behavior within the app. Like, how long do they spend? How do they use the application? How do they use the intervention? And so we could predict those users that were likely to drop out with an 85% F1 score. And so we wanted to look at how do we prevent dropout or keep people engaged. And so one way we tried to do that was human coaches. The data is still out, but people with anxiety really are, they did not love having a human coach reach out to them. And so we're looking at other ways we can translate this into a mobile platform. And what that means is we want to look at the actual biomarkers of anxiety. So people with social anxiety, they tend to socially go out, have a social event, which is stressful for them. They then in turn have anxiety after the event. And so it's a vicious cycle where they have anxiety before, concurrent anxiety during, and they might socially isolate, avoid classes, avoid going on dates, avoid even taking a job. And so how do we actually leverage those symptoms to deliver better interventions? And so what anxiety might look like for an individual, one individual might be very different from another. And so you can have subjective affective symptoms like feeling anxiety, being on edge. You can have cognitive symptoms like everybody judging me, I can't do anything right. Or you could have subtle behavioral changes like avoiding speaking. Are these like measurable things that we can measure? Fidgeting. And then you have the physiological response to anxiety. Racing heart rate, sweaty palms. And so what are these unique symptoms of somebody with anxiety? Someone might have more subjective symptoms, somebody might have more cognitive, and somebody might have a more physiological response. These are not necessarily concordant with one another. And so we need individualized models to be able to know when someone might need an intervention. And so I'll talk a little bit about some initial work we've done on smartphone-based biomarkers of social anxiety disorder. We deployed a study with smartphones to individuals across the social anxiety spectrum to look at how they use their phones in different contexts. Because we wanted to know, is there even a measurable difference for individuals that have social anxiety with those that don't? And so what we did is we have our own behavioral sensing app called Census, which you can program to collect data at different densities, accelerometry, SMS. All of this varies by platform. It's important to note, so you're not going to necessarily have synonymous data with iPhone and Android platforms. So there is some matching of these data streams if you're doing any kind of modeling at the end. But we could collect GPS and EMAs. So you heard a little bit about EMAs, ecological momentary assessments earlier. These are these more sporadic surveys to ask individuals how they're feeling in the moment, to collect that subjective data. And so we collected that data as well as a laboratory session with various self-report mental health measures, behavioral tasks, and then we monitored 75 participants over 2 weeks. And so their SAS scores, their social anxiety scores, this is the social interaction anxiety score, varied. So we had a good range of low and high social anxiety. If anyone's interested, we have this data set online as well. And so what we wanted to do is look at how these smartphone-based biomarkers varied. And so the first thing we did is we looked at location context. And so since this is a homogeneous population of students, we looked at how they spent their time on campus, at their homes, friends' homes, by semantically labeling the location, doing some spatiotemporal clustering and coming up with a set of labels that captured how they spent their time, like education, home, other houses, how often they're going to the supermarket, church, health, how often they travel outside of town, to really capture how much opportunity they had to interact with others. So these are proxies, in a sense, for social interactions. And so the next thing we wanted is communication context. So we captured how much they were texting and what was happening around when they were texting and making phone calls. Ideally, we want live interactions, but this is one of our first studies. But so this is just like we looked at the accelerometer data predominantly to see what their patterns of behavior were around texting and calling. And so we looked at the data as a linear dynamical system and looked at the stimulus around as a function of both the location they're in, so food and leisure, work, personal life, and looked at within those windows around the communications how they held their phone, like how active they were they fidgety, so basically a higher or lower stimulus based on the accelerometer data. And what we found, and just looked between low and high socially anxious individuals, there was no intervention for this. And we found that there was a significant variability during phone calls in anxious versus non-anxious participants. So anxious individuals tended to be more fidgety. So you'd have like a higher stimulus around that phone call. Confirming some prior literature in psychology, we definitely saw less of a difference when texting. There is a preference to communicate in texting between socially anxious individuals. The behavioral patterns varied by semantic locations, and particularly those that they had the opportunity to be around others, like if they were at a friend's house or a restaurant. And so seeing these patterns and digital biomarkers in the anxious individuals, we want to map this to actually, can we use this data, these physiological markers, to actually deliver interventions? And so socially anxious participants also preferred calls and text in a home environment versus outside of the home. And so that leads to a new grant we recently received to develop context-aware microinterventions for social anxiety. And so the goal of this grant is to take what we've done on the intervention front with Mind Trails and map this to anxious moments. So can we identify unique biomarkers for social anxiety? And we've divided these into 3 unique contexts: physical, where people are, their social context, and I'll talk more about this, and their physiological context. And can we develop these biomarkers that will allow us to develop a policy for just-in-time adaptive interventions, leveraging reinforcement learning to trigger an intervention in the most appropriate moments. And so we're developing this for platforms we're developing in the lab using Census, our behavioral sensing platform, and a smartwatch app which similarly collects embedded sensor data called SWARE. And so how do we sense and detect these anxious states in the wild, and what are the contexts we're most interested in personalizing interventions for? And so what are the relevant contexts of social anxiety that we've identified? What is the social stressor domain that people experience? Is it a speech? And this is targeted first at college students. So, we're looking mostly at the types of stressors that college students experience. Is it a classroom? Is it educational? Is it like giving a speech, going on a date? Is it work-related? And then we want to be able to identify the temporal phases of anxiety. So you saw those scenarios like calling out to a friend on the street, but thinking about the phases of the anxiety. You have the anxiety you feel before an event, like before you get up and give a speech. And this is what we call anticipatory anxiety. And then we have concurrent anxiety that you feel during an event. And what the ruminatory phase, or the post-event processing, the anxiety you feel while replaying those perceived social mistakes after an event. And so can we capture these unique contexts to be able to deliver an intervention for an individual? And so we ran a study, and this was unfortunately during COVID. We had planned to do it in person and had to quickly translate it to an online study where we dropped off sensors at people's homes. So what we wanted to do is control the social experience. So initially to actually recruit people high in social anxiety to different social experiences, and then be able to capture the biomarkers when we know they're experiencing those events. And so we recruited 46 individuals, and we designed a study where they would have an alone period where they should be anticipating an anxious event. And then they'd have a dyadic interaction and then a group interaction with up to 6 individuals. And so in that, we'd capture the anticipatory, concurrent, and post-event anxiety during 2 types of evaluative threats. So one is explicitly evaluative when they're told they're going to be evaluative, and the other one is ambiguous. And so we dropped off we dropped off an Android smartwatch with the app we've designed, 2 empaticas, a webcam, and a phone to complete surveys on, and then we had Zoom recording as well while they were wearing these sensors. And so here's a little bit more about the procedure. So they would sit in front of their computer, either alone. We had a video they watched when they were alone, and then they'd do the explicit and non-explicit evaluation. And so we had the behavioral data, which to capture behavioral symptoms. We had Zoom video coding, survey to capture, and this is akin to EMA data, affective and cognitive symptoms, and then the smartwatches to capture the physiological data. And so where do we want to go from here is to map this into a framework for delivering context-aware micro-interventions. And so capturing this unique data from smartwatches and phones, can we detect the physiological signs of anxiety, the subjective, affective, and cognitive signs of anxiety, predict somebody's state anxiety, and actually use that to deliver the anxiety designed to reduce their symptoms. And so this could actually be looked at a macro scale as well, where we think about interventions as multi-scale. We can deliver them in the moment to the individual when they need them most. It also could be used in a stepped care model where you notify a clinician, a health coach, to keep them enrolled in the program and ultimately prevent attrition. And so some of the work we've done thus far with the data we've collected is look at building a personalized model to detect state anxiety, somebody's self-reported anxiety, from audio signals. And so we have the data from social context and their anxiety symptom severity. And so the field is really moving towards a personalized model, but we don't have enough data to really do that. So we've looked at really doing this to actually develop a model that takes the advantages of personalized with population. And so we're looking at, can we take this data and actually take both the context and individual traits of the individual, like the symptoms of anxiety they experience, to be able to develop the best of both worlds. So clustering individuals based on both their situational context, so that anticipatory, evaluative, non-evaluative phase, and how high their symptoms are. And so what we ended up doing is clustering individuals into high and low symptom severity. And we could see that their linguistic and their audio features were different across those groups. And so you'd see things like different lengths of words per sentence, positive emotion words difference, negative emotion words difference, as well as difference in the actual audio signal. And so we took that and combined that with the situational context to develop a personalized framework for anxiety detection. And so you can look at how each of the individual set of features, acoustic, syntactic, and lexical, contribute. But the combination of these gives the best performance. So the personalized social anxiety detection, we can detect whether they're high or low from their baseline. It's a binary classification at 75% F1 score. And so we also looked at how the context and person-centered models contributed. So we looked at a model with only contexts, like their relevant social context, as well as whether the person-centered layer contributed to the model as well. And we could get better performance as long as we included both the person-centered and the context-aware layer. And so we haven't integrated in any of the physiological data yet, but we do pretty well with just audio in terms of recognizing their state anxiety. And so next steps for us are, how do we leverage this to trigger and personalize the intervention based upon physical, social, and physiological context? So we have these biomarkers in each of the categories, and we want to be able to leverage these biomarkers to deliver interventions in the moment. And so once we've extracted the biomarkers, we are using a reinforcement learning framework called contextual bandits to look at these physical, social, and physiological contexts to determine, one, if an individual is in need of an intervention, but two, if they're also receptive to an intervention. And so the reward will be based on, in the contextual bandit framework, whether they are responsive to the intervention. And so we'll have this policy, and the warm start will be from this controlled data study, and we're actually about to roll out a study where we actually do it in the field this time, to actually see if what happened on Zoom is what happens in real life. We don't know if in-person social interactions are going to have the same biomarkers. And so future directions and challenges, we need to refine these biomarkers. Mapping from a controlled study to a real-world study is particularly challenging. Do the biomarkers map? And then we need to see if can we indeed predict these anticipatory, post-event, and concurrent anxiety signatures accurately. We don't know for sure that those signatures will be that different. And so that's one of the challenges. And then from that, learning the policy that best learns how to deliver the intervention in the moment, and how much of that dose do we need. So that's one thing in the just-in-time intervention space. We don't really know the appropriate dose. And so we need to think about those short-term outcomes of reducing anxiety symptoms, getting people out and enjoying, going out and having social interactions. But we also need to think about the distal outcomes, like actual reduction in trait anxiety. And so, and all of this being said, these are all more of the clinical questions, like can we actually find the right policy? There's technical challenges of how do we not kill people's batteries with these embedded sensing profiles? Do people, are they going to stay engaged and use the device? Those human factors challenges. Because digital health is not one size fits all, identifying those individuals that need it most. And then balancing this personalized model with a population-based model. So how do we balance the need to better personalize, but the need that we have, most of these studies are small. And so we need to think about these particular challenges. And so I want to thank my collaborators in psychology and my students in my lab, and my funders, and thank you. Yeah.
Yeah, thank you very much. We'd like to open the floor for questions.
Hi, thank you for the presentation. If we think about an application scenario that's college students will be monitoring and suicide prevention, so I'm wondering, how far does it take from your research to actually have an implementation in reality? Because I find two essential challenges: data acquisition and their willingness to participate. Because if somebody has this problem, as you said, they might not be willing to release the information and be monitored. So,
Yep.
So can you describe how far do you think this research
It's a
can be?
great question. And what we found is that many individuals are willing more to go towards these digital mental health solutions more than seek out therapy. And so I think, it's up to us as researchers to work with clinicians that can appropriately explain the potential benefits of the intervention, but it's also, personalizing the digital health interventions to the individual. It's not going to be right for everyone, but particularly for social anxiety, because these individuals are so prone to avoidance. This is a unique population. I can talk about other populations where I question if digital health is the right solution, but in this case, we found that people are very willing. So.
I guess I have sort of two related questions. Mm-hmm. If you were looking to expand this into wide use, how would you get past having a wide variety of competing apps with no grounding, and having health insurance companies that people think insurance companies said, oh, you have to find a therapist, there's a waiting list, they aren't a network, and the getting to the therapist barrier, and insurance companies willing to try non-traditional solutions.
Yeah, it's a really great question, and one we are tackling at the moment. So thinking about how to get interventions into existing care pathways. And so ideally you'd think the science is what matters most, but it's not necessarily the case. And so there's a whole group called Cyber Guide that tries to, so it's clinical psychologists that go and rate apps in the App Store based on evidence, and very few of them have sound scientific evidence. But there's a lot of different pathways. We found out one of the ways to actually get into an existing care pathway is to get a lot of reviews in the App Store. And so that's not science necessarily, but yeah, so it's a hard question, and I think one the field is tackling right now. There's some examples of like Kamai that has like a suite of digital mental health apps offered through, I believe it's Kaiser. And so there's lots of different examples of how to get into existing care pathways, but there's not going to be one intervention that fits all needs. So we need a suite, and ideally that are all backed up by solid evidence. Like CBMI is not going to be the answer for everyone. It might be mindfulness, and so the idea is this framework, with embedded sensing to sense anxious states, could be a part of any number of interventions.
Thanks for the presentation. It was very interesting. I have a question. Maybe it's a philosophical question because anxiety or any behavior that human has an evolutionary background. So not every anxiety is bad. And in medicine,
You're exactly right.
in medicine, we accept an anxiety to become disorder if it impairs you, and that we call it. So in this group of college students, did you look at people who had the disorder versus the one that had just anxiety?
Yes, so in the study, so I presented two different studies. The first one with smartphone-based biomarkers was a continuum. So it was low and high, so across the continuum. So we could look at symptoms across individuals with and without social anxiety. And the second was only individuals that were high. Purposefully, because that's who we're designing interventions for. These are the individuals that avoid interactions and are impaired socially because of it. So yes, that's the great point. Yeah.
Thank you for your talk. Again, going back to the Wild West and the App Store, do you think these interventions should go through the same regulatory process as therapy, for example, or how do you envision that?
Yeah, I believe there should be some regulatory process, but I'm not sure that we're there yet. So, there should be some scientific evidence to back up interventions, yes. I think there's only 2 right now that are digital therapeutics that are FDA approved. There's very few. Yeah.
Dr. Barnes, I'm here in this.
Oh, I'm sorry.
That was a great talk. Thank you so much. When it comes to social interactions and potentially also the travel profile of individuals, how would you determine normal? And then how long does it take? Because there is a rhythmic, a travel profile on Monday is going to be different than Sunday. How long does it take for you to sort of figure out what that normal pattern is? And then how do you identify any abnormality or any deviation from that?
Yeah, that's a good question. We've thought about this, and ideally we want 5 weeks of data. However, the longer people are enrolled, the more likely it is they drop off. So 5 weeks gives you a good sense of like monthly patterns. And as for what's normal, I think you're asking what's normal for them in terms of social interactions. Is that your question? I want to make
So
sure.
when you feed it to your algorithms, how would you define, like what kind of cues would you provide to your AI algorithms that look for these patterns, this determines that
Well, so we have a combination of those affective and cognitive and behavioral and physiological markers, which aren't necessarily concordant. And so I think the intervention delivery ideally is going to be a combination of those. And so it's going to be personalized to the individual. And so what's normal for one individual might be very different for the next person.
So, in keeping with that question, when I was much younger, I did a lot of psychophysiological research, and one of the things that we found quite troublesome in terms of modeling it mathematically was what we called at the time, maybe it's a different term now, response stereotypy. That is that you might be a sweater, but I might be a fidgeter, somebody else might be a hyperventilator, and really the only time you saw these elements sort of co-vary with each other as you would expect autonomic responses to do so would be when they were maxed out, right?
Right.
And so are you finding that you're able to sort of is 5 weeks enough to establish sort of the response stereotypy of the individual so that you can then begin to monitor changes? Is that sort of part of what you're doing?
Well, 5 weeks was more of like in a university student, you get a cycle, like you get a good cycle. In terms of this particular work, I think you're dead on in that you don't have concordance between all these signals, and that's one of the problems. And that's why we're looking more towards individualized, like our cluster-based models that group. The symptomatology is not going to be the same. In fact, I think some of the work is mixed in the psychology literature. Some of it says the more socially anxious you are, the more discordant you are. And so that in itself is a marker. And so we don't have enough data to be able to answer that yet, to be quite frank. So, yeah.
Hi, thanks for the presentation. Very, very interesting. I was wondering about if you thought much about the negative impacts of the science in general, because humans can't really disguise autonomic responses. You could imagine a North Korean dictator requiring everybody to wear an Apple Watch, and he knows when you took it off. So, so have you thought anything about those kinds of things?
Yeah, so let me parse your question, thinking about like how people use the technology or not use it when they're in a particularly anxious state. Is that sort of what you're getting at?
Well, the technology, the science of what you're developing, because you're having some components that are near term that you
Mm-hmm.
push it or no? No? Good, okay. You're looking at the science in general, so there are things that you're projecting. There's other things where that projects regardless whether you're projecting it, and there are things that you're handling right now. Mm-hmm. Sometimes when we look at research, we may apply it to some medical thing, but even if you're doing DOD research, so often you'll apply it to medical stuff. It has another application down the road. So in this case, it enables you to monitor human beings, to understand at some point, and not at this level, but at some point, a way it's mapped out, when they're being anxious, when they're being maybe secretive, whatever wind up they have to their behavior. And so one machine could monitor millions of people, one cloud machine, one instance maybe. And so I just wonder if you thought about those things. It seems like maybe those are other research avenues for people to get into.
Yeah, and I think in the context of all of these interventions, we have to monitor carefully for etiogenic effects. So like, are people getting worse as a result? That's why we have two kind of outcomes we need to look at, the proximal and the distal. Like, are they getting better in the short term? Are their symptoms reducing? But what are the long-term outcomes and the reduction in actually trait anxiety? And so we always, in any of these interventions, have to monitor for those potential harms. And so these aren't, meant to be used forever either. Like, when do people, I think we also have to answer the question of what is the appropriate dose and when should they stop using it and move on. And it's not going to be right for everybody. I don't know if that gets at your question, but yeah.
Yeah, thank you very much.
No.
I think, we will be continuing our discussions over next. So we have ice cream break, short break. Then we will be continuing with other talks. So let's join in again in thanking Professor Barnes. Thank you very much.